Good evening, everyone, and welcome to tonight's RAMI webinar. We are the Regenerative Aesthetic Medicine Institute, and if you don't know us, we're all about sharing education in regenerative aesthetics. So tonight, I'm delighted to have Professor Lee Walker joining us. He's one of our scientific committee members, and tonight he's going to be talking about addressing regenerative complications. So he gave this presentation at Ramsey, our annual conference in November just gone, and it had an amazing response for people. So what we asked him to do was give a bit of an update and share it with you guys tonight, where it's going to be about 45 minutes and there will be time for questions and answers at the end. If you see the more button at the bottom of your screen, there'll be a section where with a Q&A, pop your questions in there, and once Lee has finished presenting, then we'll run through some of those questions. Before we get started, we just want to do a little poll to find out about you and your experience. So we should have something popping up on the screen now. If you can let us know your medical profession, please. Doctor, dentist, nurse, pharmacist, or other. Thank you very much. There we go. And our next question should be popping up any second. There we go. We just got all of those details coming in. So did you attend Lee's talk at Ramsey last year? Just so we know exactly how to position it this evening, he is going to have some updates for you. Just be good to know whether you've had some insight before. And it looks like the majority are no, so 80% didn't attend in November, 19% did. So that's really helpful information for Lee. And then our next question, I believe, is on our membership. Are you subscribed to RAMI? So let us know if you're subscribed. As well as having early access to things like our webinars and our discounts for our conferences, then we publish a quarterly journal. So there's our latest copy, and that gets sent out to you free of charge. And it's lots of articles covering everything in regenerative aesthetics, and it's about half and half. So after this webinar, we'll send you an email and there'll be a link in there to sign up for those of you who aren't. I believe our final question is coming up. And this is just to get an idea of any future topics you'd like to see. So if you can pop some thoughts and ideas in the box below. We do have some already booked in. So on May the 11th, we've got Anna Baker, and she will be talking about tissue changes from GLP-1 therapies and how to treat these with regenerative treatments, which is going to be super, super interesting. And then in July, we have got a full series. So every Wednesday in July, we will be talking about genetics and regenerative aesthetics. And that's going to be hosted by Gustavo Torres. He spoke for us at at Ramsey. And he's an absolute expert in genetics. That's going to be super interesting. As well as we've got Cameron Amjad talking about imaging and imaging technology. That is in May as well. All of them are on our website that you can register for. And we'll send the links out after this webinar. Okay, so I think we are ready to go now. So I am going to invite Professor Lee Walker to join us. And I'm not sure how many people know Lee, but he's very, very well known for as well as being an absolute expert practitioner, but very big in the training game and educationally, aren't you? You spent years and years and years training people, as well as being part of CMAC, which is all about complications in aesthetics. So perfectly placed to lead tonight's webinar. So I'm now going to hand over to you, Lee. Talk us through everything you have got to share. Like I said, people can pop questions in the Q&A at the bottom of the screen. And once Lee's finished presenting, we'll then run through as many as we can before wrapping up at 8 o'clock. Okay, over to you, Lee.
Thanks, Chloe. I think that's a very polite way of saying you've been around the block a little bit. So, yes, as Chloe said, I have been involved in training and medical education globally for quite a while now, and it gives me a great pleasure to to deliver some information and education to you guys as part of RAMI, which is the Regenerative Aesthetic Medicine um, Institute. So what I want to do is I want to share my screen. So I think we're stuck on Chloe's screen, so I can't see mine. So Chloe, I think you may need to give me a little bit of a second to try to share this. Okay, because it's not allowing me to share. So if I just close this and then I'll go back. Okay. So as Chloe said, I've been involved in complications management for quite a while now, and it's a very, very interesting part of anybody's work. It's not a glamorous area to work in, but it's certainly one of those areas of clinical practice, I feel, which is incredibly important because it's a real big opportunity to learn. Chloe, if you can just give me a thumbs up if you can see my screen, or someone give me
There
a
we are. It
thumbs.
should be working.
Okay, so you can see my screen perfectly.
Yep.
Okay. Now that we got over the technical issues, I really want to start to talk about the dark side of repair because we look at aesthetic medicine and more importantly, regenerative medicine as being the less, I would say, risky side. And because we tend to inject things which are maybe they're uncross-linked or maybe they're a little bit superficial. So I want to show you some of the very interesting cases and draw up a list of things that you might not have highlighted. If you've seen this lecture before, there's lots of consolidation here, but there is new information. But if you haven't seen it, it's quite an interesting sort of spin on complications. And some of them are incredibly common, but they get very challenging. So there's a little bit of everything for everyone embedded within here. Before I start, it's really important for me to say that anything injectable will act as a foreign body. Now, it's just the host's response from maybe a couple of macrophages just sniffing about to quite a large, intense foreign body reaction with a fibrotic component to it. And this is from a publication by Christensen almost 20 years ago now. So I think that one of the things that we have to understand as practitioners is everything can act as a foreign body once it's been injected. And this is some of the sort of etiology of the pathogenesis of some of the things that we understand now. It's very complex, but we have extrinsic and intrinsic factors which may cause complications. So we may have infection, we may have trauma. There are different drugs, vaccines, and unknown extrinsic factors here. So it's really about what you're injecting, so your filler characteristics or your injectable characteristics, and how the host responds. So it might turn up as something very strange, like a biofilm, which is a very complex and difficult thing to treat because biofilms are what we call quiescent. They often are very quiet and cold, and then they will become activated, become red, inflamed, and incredibly angry. Your typical foreign body reactions can just look like cardinal signs of infection. Then you'll have your type 4s, and then you'll have things like adjuvant-based filler reactions, Asia. So there's an adjunct inside, which is causing a problem. And anything can cause this fibrotic response. So as practitioners, as healthcare practitioners, what are our obligations before we inject products and before we do anything with our patients? Well, it's all about education for both yourself and for the patient. And if I was to draw aesthetic medicine right now across the world, it'll be this, because there is often no clinical rationale or reasoning for what people do. Now, just because somebody else is doing it, it doesn't necessarily mean that it's right or there is a sound clinical rationale behind it. It's, oh, I've seen this, I thought it looked good, and I'm going to do it. And again, just keeping on the theme of social media and how it will maybe influence some people to try different things. You look at the guy on the left here, And this is pretty much what we see pretty much day in, day out within aesthetic medicine. So again, your driver should be specific evidence-based medicine through reputable sources and not using social media as a guide to injectables. And again, it's just because of these things that you see. This was a big storm in the US, PGDF, so platelet-derived growth factors, and how different influencers were injecting these products into patients when it was for topical use only. And there's been a plethora of complications happening, and unfortunately, patients have been harmed, and now there's a litigious process going on. So again, these are the things that we really need to begin to understand, is that everything that we have to do has to be either a medical device, a type 3 medical device, the CE markings with phone numbers behind, with a large amount of clinical evidence behind, or it's FDA approved. We just can't do things like this. Just because regenerative medicine is new, it doesn't mean we have to pioneer by injecting topical substances into our patients. Again, just on these themes of interest here, we look at data which has been provided by what we call MAUDE. That's MAUDE, and that's the manufacturers and users device experience. And it's for cases or complications which have been reported to the FDA in the US. And if you look here, there is a significant outlier amongst the products available here. And you can see a resounding almost 75% of delayed events of complications, nodules, were with a certain brand. Now, that certain brand has low molecular weight as their predominant hyaluronic acid component. And we know just very simply from physiology is that certain amounts and certain sizes of low molecular weight can have an indirect pro-inflammatory response on the immune system. So we're starting to really understand the products that we're injecting and the things that we're seeing associated with the physiology behind. So let's have a little sort of look at this case here and look at the cycle of what's happening. And you can see there's been some treatment in the glabella. And unfortunately, it's led to scarring here, because anatomically, it's an incredibly challenging area to find the right depth. Obviously, people will be thinking about supratrochlear arteries here, but we also have the central artery, central vein, paracentral artery, paracentral vein, radix artery. We have lots of different arteries that we don't normally talk about in aesthetic medicines. And it's really a high traffic area for vascular problems. So if I was to ask you what product caused this, you'd probably say some sort of hyaluronic acid. Well, this was PRP, and it led to vision loss. So these are the things that we have to become aware of. Within regenerative medicine, there are some significant and catastrophic complications which may occur, which you don't think would be linked to the product you're injecting because it's not cross-linked, or because it's autologous here, you don't have any issues with it. Well, there has been numerous cases of visual complications for lots of different filler materials for 120 years. And you can see the predominance was hyaluronic acid and autologous fat. But when we have a look at this in a little bit more detail, you can see, obviously, we're injecting now a lot more hyaluronic acid, but the number one used to be autologous fat. We have collagen, then it becomes biostimulatory with CAHA, PRP, PLLA. Sodium thiosulfate is something that we thought we could dissolve calcium hydroxyapatite with, petroleum jelly, and lidocaine. So you can see there is lots of injectable products which have the capacity to induce vision loss within our patients. So what other factors are available? And we call these the three Ps. So we have patient factors, we have procedural factors, and then we have finally the product. And this leads to late onset reactions that we often see. So obviously your patients, you're looking at different medications, whether they've had what I call polyrheology, so many other different fillers. So, there's a big risk of biofilm. Different procedures, so like facelifts, threads, lots of different things, whether they have any um, subclinical infections, maybe some dental issues, whether they have had the recent vaccines or they're allergic. So again, product's very important here because there are now brands that are saying we have no low molecular weight fragments or we are purified, because a lot of the impurities in the early days were causing most of these problems. Particles characteristics, so size and shape of particles and even charge of those particles, has led to people now theorizing the shape of these particles is a little bit pro-inflammatory. And then obviously the things that we should be looking at is aseptic technique, if that's ineffective, rapid injections, aggressive fanning, touching cannulas, large boluses, and intramuscular. So there's lots of things that would lead to a potential late onset reaction with any injectable. This is quite a useful slide for you guys because you often see on the consent forms autoimmune disease. So I was part of this publication looking at late onset reactions. And this was done in conjunction with the university, the dermatology department in Poland. And what we looked at was low, medium, and high risk for autoimmune disease. And you can see low grade for fibrotics, it would be vitiligo, alopecia, and type 1 diabetes. Moving up to your medium risks, your localized scleroderma, Hashimoto's, and then your high risks. And these pretty much are a no-go for me in clinical practice. So your rheumatoid arthritis, cutaneous vasculitis, SLE, psoriatic arthritis, and systemic scleroderma. So those have the potential to be incredibly difficult to treat with these nodules further down the line. So we're going to look at biostimulators, and I know these are incredibly popular at the moment, and these become incredibly popular at the same time as hyaluronic acid was getting a little bit beat up about the overfilling. But biostimulators in different guises have been used since the 90s. They're nothing new. Technology really hasn't changed. What's changed about biostimulators is how we use them and how we reconstitute. So they were volumizing fillers at the beginning. Now they are skin quality, let's say, products, because now they're becoming a little bit more hyper diluted from their early days. So again, what I want to do is pose a question here to you. When you look at this statement, what would this statement suggest? So multivariate analysis for factors associated with vascular occlusion with needle injections found that polylactic acid was associated with 72% lower odds of an occlusion than hyaluronic acid. Some of you may say, well, that doesn't really suggest anything. Or some of you may say, it actually may look like polylactic acid is safer to use with a needle. And I don't know how many amongst you would use polylactic acid with a needle in different areas of the face. It's often recommended to use a cannula. But what it does suggest is that people would look at this and think about risk mitigation and say, oh, I'll use polylactic acid with a needle. It's obviously a lot lower than hyaluronic acid. But when you do a little search on here with polylactic acid and complications, you can see that there is, these are just a few. You can see there are severe visual loss, different types of occlusion, different kinds of blindness, different types of nerve issues, bilateral hemifacial spasm. So again, what you have to look at the literature and stand back. As I said, I was the global chair for a complications group, and we see pretty much everything. So these products are not safe in terms of it's a free hit for you. All products, every single product on the market, once you breach the skin envelope, have the potential to cause an immune response, a vascular occlusion, or issues with blindness and beyond. So just take that into context. Again, this is a very unfortunate case. It was a case that was part of a publication by one of my dear friends, Danny Suarez, and it's looking at the maxillary artery, which is deep. And you can see here, somebody's attempted to volumize the anterior midface with a calcium hydroxyapatite to maybe volumize and stimulate the skin, but unfortunately left the patient with a rather nasty occlusion here, which is manifesting not just extraoral, but it's intraoral as well. And we know that the infraorbital artery, which has been injured here, is both extra and intraoral. Now, the problem is here, how are you going to fix it? Now, a lot of you say, oh, I'll just use hyaluronidase because that's what we're told. Well, it gets a little bit more complex. So when you look at an algorithm here for vascular complications with biostimulators or non-reversible, they tend to get a little bit complex and convoluted. And, there has been reversals of these, but in my experience, these are always going to go pretty much to the wire, and maybe most of them end up in plastics. So again, should we be using things like calcium hydroxyapatite to volumize? Now, I know it's great for skin quality, and you can use a cannula, a little bit more superficial here. So again, we have to take a little bit of responsibility. I did put a slide up saying about obligations, to understand that this is not a volumizer. So placing it deep in and around foramen of large vessels, you're going to have a real big problem, because it's complex, the management, once it has a problem. And again, with biostimulators, so this is collagen biostimulators and PLLA, and you can see these huge nodules here, which are placed superficial in the neck. And these are pretty much are reminiscent of, if you go back as long as me, like Chloe intimated, I do go back a little bit through the annals of history. And these are the type of things we've seen in the mid-face with the more concentrated PLLA injections here. So very, very difficult to get rid of these things once they're in situ. And you can see that this is just for nodules of polylactic acid, and the complexity behind the management of these things. So again, our understanding of polylactic acid, calcium hydroxyapatite, and other biostimulators, polycaprolactone, is improved massively. But its management is always, always, always a lot more difficult than your traditional hyaluronic acid fillers. Polynucleotides, probably the fastest growing injectable that I've ever seen within clinical practice. And it was one of those wonderful things in regenerative medicine that made a lot of clinical sense, and it gives people almost the freedom to inject and improve skin quality with what they thought was very, very low risk. So we have to understand what normal is before we begin to understand what abnormal is. And this is typically what you would see with a polynucleotide injection here, just intradermal into the skin, exactly where you want to deliver it. And you just see these papules, and within a couple of days, the erythema and the little bumps, they tend to go away. And again, we're looking at things like this, and does this look normal? Well, you'd have to say, no, it doesn't. So this is around about a week after we've seen a case of injectable topical product that they thought was or they told us, was polynucleotides. And a couple months later, this was what we saw. So it's a granulomatous response. We don't think it was polynucleotides, which was injected. Remember, your patients and some practitioners will lie, forget, and lie. So you're going to have to deal with this. This patient made a full recovery after having a referral into dermatology where they use steroids, lasers, and everything else to treat this patient. So these were little granulomas which were confirmed with biopsy. The number one complication that you will get in aesthetic medicine is malar edema. Now, it's the number one complication with hyaluronic acid, but it's also the number one complication with polynucleotides. And this is how it manifests. So it's anatomical, but it's also product related. And this is what it looks like. So you have your polynucleotide, which is your injectable, and then you have a very thin skin of the under eye area, the lymphatics, and then you have an enclosed space. So with your polynucleotides here, you have a very, very strong hydrophilic, negatively charged phosphate backbone, which is going to drag a lot of water in. And what we've seen is that there are brands on the market where they have a lower concentration of polynucleotides, which are specific to the eye. Now, I know a lot of practitioners are saying, oh, but my patient had thicker skin, or it didn't really work, so I went up. The more you go up in terms of concentration, the more of a problem you're going to have, because the more you're going to have those strong hydrophilic, negatively charged phosphate backbones resident within the tissue. So the thin skin will dictate that you inject your product superficial, as intended. But the lymphatics are slower and predominantly superficial within this area, and there is nowhere for the water to escape. So this is your classical recipe for disaster, where product and patient anatomy is really coming to the fore, and it's causing problems. So let's summarize what's happening, the mechanism and the management of polynucleotide swelling. So within the first day to 3 days, you've got the hydrophilicity I've just spoken to you about the negatively charged backbone, and it's drawing in water. So again, you would just put a cold compress and to massage outwards. You also have an osmotic effect, the local water influx into that trap zone. Again, just massage, mild inflammation through this receptor-mediated vasodilation, which is self-limiting, and then your technique trauma. Now, what's interesting about technique trauma is there was a large publication, a meta-analysis done by a team from Galderma, Andreas Nikolaus, and they looked at the infraorbital area, needles and cannulas. And what they summarized within this publication is that needles will cause significantly more bruising, but cannulas will cause significantly more edema. So I have seen, again, excuse me, people injecting polynucleotides with a cannula. So that's pretty much putting petrol onto the fire in the infraorbital zone. So let's do a little bit of regional anatomy here. So what you can see is a ligamental system which is made up of the orbital retaining ligament, the tear trough, and the zygomaticus cutaneous ligament. And your tear trough ligament is separated by the palpebral and orbital parts of your orbicularis oculi muscle. The green line that you see, number 6 here, this is the lateral boundary of what we call the malar septum. So from position 2 here at the medial canthus, all of the way to the lateral canthus, we have this enclosed space. And this is the space that we tend to inject those polynucleotides into. And this is the lateral boundary here. You can often see swelling is trapped between 2 ligaments. and your lateral canthus here is the boundary, and you can see it with infraorbital swelling and also black eye hematoma here. It doesn't really move out of this fixed space. So this is the fixed space I'm talking to now. Dividing that fixed space into a superficial and deep aspect, or a superior and inferior, is a structure which we call the malar septum, and it's this little white structure which goes from the orbital retaining ligaments and inserts into the cutaneous aspect here. This is what we call the malar septum. And this malar septum that you can see, please excuse my drawing, they're very elemental, but it's just meant to be conceptual for you to understand, is that it's dividing the fat into two. And if we place our product a little bit too superficial here, then it has nowhere to go, because this malar septum here is an impermeable barrier. And this work was done by David Funt in 2011, surgeon out of New York, and then followed up by Newbury and his team. And both come to agreement that this malar septum, this structure here, the fixed space and the lymphatics, is what causes malar edema. So we know we have a hot spot here for infraorbital swelling. And as you can see here, the predominant of the lymphatics, so your lymph capillaries and pre-collectors, they're all superficial and they drain through those layers. Now, from your medial canthus to your mid-pupillary line, so basically your tear trough, we don't have fat. So all of these lymphatics here are just in the skin, and they will drain into the deep spaces and then follow their way either into the submandibular gland or into the parotid. They normally follow the patterns of the venous system, so the veins of the face. So they're pretty much predominantly superficial. And what you can see here is the pathway. And the pathway here is the inner canthus of the eye. It's going to follow the facial vein into the submandibular. And then we're going to have the majority here draining into the preauricular and parotid areas here. Now, what I want to draw your attention to is the actual space between those two fixed ligaments. Right here is that watershed area where the lymph can move one or two ways. So it can go medial or it can go lateral. And if you fill this area up with water, this is your problem. It's just going to get caught because these lymphatics, they don't have any valves. So they're avalvular. So it can move both ways. And this is a pretty, I would suggest, a pretty frustrating complication for your patients. So I want to discuss a phenomenon which it's applicable to both polynucleotides and HA. Hyaluronic acid is also a biostimulator. If you look at the classic definition, biostimulation, collagen, elastin production after injectables, it's a non-inflammatory biostimulator, whereas your traditional biostimulators are inflammatory. So what happens is we have these fixed ligaments, and then we have this space in between with all of the lymphatics, the malar septum, this watershed area where the fluid can go either one of two ways. And if you start placing little drops of polynucleotide, for example, here in between, what we're going to have is a phenomenon called isovolumetric edema, because each of those negatively charged phosphate backbones that we're injecting is going to draw water in. And it's the same with hyaluronic acid. As it breaks down in this area here, each fragment will then attract more water, and you will end up with that classic malar edema, which is defined as infraorbital swelling between those two ligaments. So again, this is why it's super important to do your patient assessment, the consultation, think about the concentration of your hyaluronic acid or your polynucleotides in this area, and choose wisely with good clinical reasoning and rationale. Malar edema, it can be very, very easy to fix, but it also can be extremely difficult to fix. So one of the things that you do is you obviously do your patient assessment and your clinical history. And I always say, for the first 2 to 3 weeks, just use watchful waiting and reassurance. A lot of these cases, they just tend to disappear as quickly as they arrive. So again, as part of your consultation, say to your patient, there is a 2 to 3 week wait. I always say 3 week waiting period, because we expect this area to swell up a little bit, and it depends on you, the host, as how much swelling you're going to have. So after 3 weeks, if there's no improvement, then you can suggest, again, just non-interventional things like head elevation, lymphatic drainage. And then if you've used hyaluronic acid here, then you can have a conversation about dissolving it, the use of oral corticosteroids, and then it gets a little bit deeper. So if you haven't managed this, or it hasn't gone away after 3 to 4 weeks, and you've done a couple of interventions, then I would refer this to a specialist for further investigations. If you've used hyaluronic acid, it could be that the product is sitting behind the malar, the orbital septum, and you could have a persistent malar edema. Those patients would require an MRI. So again, there was lots of things that we took from the evidence here. But if you're going to use triamcinolone, make sure that you've used it before. Make sure that the patient is a good candidate. So injection of this superficially can lead to telangiectasias, skin atrophy, and other problems here. So if you're not used to using these things, then please refer them off very, very quickly. Again, exosomes, we can and we will see things like these little granulomatous responses to this, because one of the first slides I put up was anything can cause an immune issue, and it just depends on the host. And again, these are some of the things you're likely to see. So this is complications of exosomes, exogenous growth factors. All of these things are now popping up, PGDF, peptides, and everything. What you're going to see is pretty much what you see here is what we tend to see. So redness, sensitivity, itching, things like what look like a type 4 hypersensitivity. Then you get into your granulations, and then you get into your infectious components here. So we see a bit of everything with these things. Again, on the market now, within the Asian market, they're seeing lots of issues like this. And I did put a slide up about Instagram and about PGDF and other growth factors that you're going to inject. And normally, if these products are not for injections, they tend to end up in a very bad way. So if it's not a product which is licensed, then I would run a country mile from these things. These are some of the things which are, again, likely to cause you a granuloma. If you're bored and you want to get to sleep, or you may have insomnia, then this guy here, Gottfried Limperl, is the godfather of granulomas in aesthetic medicine. Interesting when you read some of his publications about, repeated injections, large injection volumes, the products, the particle size and the smoothness, the charge, the hydrophilicity. All of those things have the potential to cause foreign body granulomas within the tissue. So again, using reputable brands, understanding complications, how to avoid, recognize, and manage is incredibly important. Again, these are some of the things that you do not want to get involved in. And I put these things up to show you that they literally throw the kitchen sink at these things. So bleomycin, cancer drugs, steroids, gout drugs, everything in between, autoimmune drugs, surgical therapy. Like I said, if you're struggling with a complication, reach out. You've got different groups now that help you along the way. And there is now a growing band of people within the hospital system who's starting to understand injectables and some of the complications we see. But I would say that just reach out to one of the complications groups. You're more likely to have a better outcome and a better response. So if you do unfortunately get a granuloma, this is some of the things that you might want to confirm. So diagnosis, not many patients would like a biopsy with a granuloma, but a granuloma can only be confirmed with a histopathological report. You can use the steroids, which you gradually taper off, and then different antibiotics. So these have been evidence-based: clarithromycin and doxycycline. Hyaluronidase, again, if it's HA, but also if it's non-HA, because you often get a fibrotic capsule, which hyaluronidase will go through. And then if you're getting into the muddy waters of triamcinolone, allopurinol, and excision, then just refer off as early as possible, because you're going to have a huge issue. So I want to say thank you. And as we used to watch Crime Watch, please don't have nightmares. So what I'll do here is I will stop the share and I will ask if there's any questions. Chloe.
So much, Lee. That was an excellent presentation. I'm sure everyone's taken a lot away from that this evening. If you have got any questions, please pop them in the Q&A box now. We've got a first one in. Can you please explain how best to identify maloseptum landmarks? Thank you.
Yeah. So, I mean, that's a great question. Some people it's super obvious, and others it's not. So the boundaries are typical, your inferior orbital rim. So you can feel that on yourself. So that's the easiest one to find. The second easiest one to find is your medial canthus, which is the medial aspect of your eye, and then your lateral canthus, or your lateral bony orbital rim. So that will be the superior, lateral, and medial boundary. It's the inferior boundary which catches most people, because it's this little cutaneous ligament here. Now, some people have a very tight, fixed cutaneous ligaments, and you can see that. You can sometimes see it on children, those type of things. I would say around about the alar crease. So if you can't see it, I would just run an imaginary line horizontal from your alar crease. So that would be the boundary. So within that space between your orbital rim, your nasal crease, the medial canthus, and your lateral canthus, that's your no-fly zone for placing hydrophilic products into, or too much of. Okay. But that's a really good question. Thank you.
Thank you. Next question. Can you please explain how PRP can cause complication?
Yeah. So again, injecting into the vascular system, we always think about the traditional embolus, don't we? You know, something which we've injected, but we don't often think about thrombus. So injecting PRP into a vessel can cause a thrombotic response, and that thrombus can get bigger and bigger and fire off somewhere else and cause blindness. So we've seen now a couple of cases with PRP and thrombus formation within the vascular system, and it just goes into the eye. There's also, I think, there's a case of stroke now with PRP. So yeah, so anything intravascular has caused a problem. There's also triamcinolone. So again, like I said, be careful with these things. You know, it becomes crystalline inside, and again, those things can be prothrombotic. We know that hyaluronic acid is prothrombotic. So again, if you're treating a vascular occlusion, this is why we always say now about the use of aspirin in conjunction with hyaluronidase, because you have a red and a white clot at the same time. So those are the proposed mechanisms and theories behind PRP injections and blindness.
Okay, thanks, Lee. And then obviously, you know, these treatments are new, they're exciting. Would you say some clinicians are perhaps overestimating the safety of them by talking about them as being natural? And what kind of thing would you say practitioners should be telling their patients and warning them about?
I think the first statement I come up with is that anything injected can cause an issue.
Yeah.
And I think as soon as we start using the word safe, that's the problem, because safe means no risk, and no risk means, oh, I can do whatever I want with the product. And because we're so used to using cross-linked products, is that we always think about these as being a gel, which can cause a mechanical blockage. And if we think about uncross-linked, it's, oh, it can go in and it'll just disperse evenly. It doesn't work like that, because like you said, these are being um, suggested as an alternative to filler. Oh, I don't want tear trough filler. I had swelling under my eye. It's okay. I'll use these polynucleotides. They're not hyaluronic acid. They don't cause swelling. And we know there's different concentrations, and we know that some people choose the stronger concentration because the skin under the eye is a little bit more old or crepey, or they want a quicker result. And this is the problem. It's understanding the science behind the edema, which is causing the problem. It's not because it's cross-linked. It's because it's very hydrophilic. It loves water and it will draw it in because of that negatively charged backbone. And again, that could be part of the company's education, is that they really haven't highlighted the fact that these complications, because often malar edema is a transient complication, but sometimes it can be persistent. It can be persistent for quite a while, and it can leave the patient leading a very sad and miserable life for a while. So I think it's that classical, what you just said. It's new and it's misunderstood,
Mm.
and you only learn through through experience, so to speak.
Yeah, absolutely. Are you aware of any reports of adverse events with amino acid injectables?
Not at this current time, but the more we do, the more we'll see. It's
Yeah.
it's just statistics. So again, anything injected, and it mightn't just be the impurities of the product or the product itself. It could be something which I highlighted pretty much straight away. It could be a patient factor and a practitioner factor. So the patient could have an autoimmune, which they haven't disclosed, or maybe the practitioner's overlooked. And then there's been poor aseptic technique, and there's a combination. So it turns out like an acute infection, or one area where there's a little granulomatosis response. So it's multifactorial. It's not always linked to the product. It's normally a combination of things. Poor assessment again, or over treating,
Yeah.
classic,
Yeah.
with these things, but nothing on the radar for amino acids, but they are very new,
Hmm.
and they will pop up as more and more people are investing their time and knowledge into regenerative medicine.
Yeah. Okay. Do you feel that nanosoft needles are any safer in terms of edema in the periorbital areas?
Not in my experience. Anything which is going to go into the skin is going to cause some sort of erythema, redness. It's again down to those multifactorials. I've seen people inject, like, let's say, with not the gentlest pair of hands, and they've used tiny invisible needles and those type of things, and there's been bruises, redness, and everything. So um, just be aware that anything can cause, that erythema, the hematoma, the trauma within the tissue. But it goes with logic. If you're using something super small rather than something bigger, you tend to are mitigating your risk, but it doesn't exclude you from any risk. So yeah, not in my experience.
Okay, thank you very much. And I think we've got a really good question to wrap things up with now. You mentioned that we can reach out to complication experts. Can you give some advice on how do you do that? How do you have that referral system and that network in place if something does go wrong?
Well, when you go to all of these wonderful places like the Ramsey conference, and then you see other experts, and any of these complications lectures that you go to see, there is a wonderful organization called CMAC. So the Complications in Medical Aesthetics Collaborative, and they're online. And I was one of the founder members. I was the chair for 4 years, and I think we published around 8 to 10 um, publications on complications, which are open access. They're always open access. And it's a very small retention fee to get on board, but you will be given webinars by this group. They have a support helpline, which is 24 hours, 24/7, 365, helping with different complications. And you've got experts from every field of medicine to help you. That's called CMAC. That's where you can reach out, and you can reach them on Instagram as well. So that would be my point of call. Again, if you are working in a hospital, I'm very fortunate. I'm very close to St. Paul's Eye Hospital. But I've got lots of colleagues in ophthalmology, ocular plastics. those types of things. And it's just making a referral pathway into those derms and those type of things. So start putting your feelers out, start smiling and being nice to people and buying them a drink and say, oh, if I have a problem, can I pass it over to you? And they're normally very, very happy to help.
Yeah, that's brilliant advice. Thank you, Lee. Um, that was an excellent presentation. It will be available to watch back. If anyone has joined late and wants to watch from the start, then we can send that out to you afterwards. So just drop us a message. If you'd like to see Lee in action at Ramsey in November, then do sign up. We've got an early bird offer on at the moment. It's only £100 plus VAT. That's November the 7th in London. And like I said at the beginning, we've got lots more webinars coming up. So do visit our website to check out the dates. And thank you so much for joining us. And thank you very much, Lee. We hope to see you all again soon.
Thanks, everybody. Thanks, Chloe. Appreciate you all.
Bye.
Take care.